Tonight's presentation is part of a 2-webinar series on infection prevention and control, sponsored by the American Academy of Pediatrics, the National Academy of Pediatrics, through a Project First Line grant from the CDC in collaboration with the San Bernardino County Medical Society. Session 1 took place last month, and it was presented by Dr. Ken Zangwill. If you missed that presentation, I encourage you to go to our webpage that we created for this program, which I will put on in the chat. The recording is available on the website. I would like to introduce our speaker for this evening. Dr. Ishminder Kaur is Assistant Professor of Pediatrics in the Division of Infectious Diseases at the David Geffen School of Medicine and Medical Director of the Pediatric Antimicrobial Stewardship Program at UCLA Mattel Children's Hospital. Dr. Kaur received her medical degree from Dainan Medical College and Hospital in India, completed her pediatric residency and chief residency at Albert Einstein Medical Center in Philadelphia, and completed her pediatric infectious diseases fellowship at St. Christopher's Hospital for Children, also in Philadelphia, Pennsylvania. You may read her full bio on our Infection Prevention and Control webpage via the link that I will now put in the chat. Please welcome Dr. Ishminder Kaur.
Thank you so much for that introduction, Dr. Tereses. And again, thank you for this invitation. Thank you, and thank you to the chapter. My hope is that over the next 1 hour, we will spend time talking about, things that we know from the beginning. We'll spend a lot of time talking about vaccines, but we'll set up the framework of the disease-associated viral shedding. How much of immunity does a natural infection afford an individual? How much do we know about that data? What is the reinfection potential of COVID-19? What do we know about variants, and especially in the setting of vaccine or in the setting of reinfection, and how much have we understood since we rolled out the vaccines about their vaccine-afforded protection? So, to begin with, just very basic, this is something we all know now, how SARS-CoV-2 enters the cell, but this was the big basis of choosing a target to find an immunogenic target that we would utilize for vaccine. So we know that SARS-CoV-2 utilizes its spike protein binding to the cellular ACE2 receptor. We know that the spike-2 protein needs some amount of priming, and at the beginning stage of the pandemic, we thought, they're really dependent on our human proteases like the TMPR SS2. But later on, we found the spike protein itself, within itself, has its own convertases, which can prime it. So it's really not dependent on the host to let it enter. And those receptors, whether it's ACE2 alone for sure, or whether it's co-expression of ACE2 and TMPR SS2, is what really determines the cell tropism of this virus. So we know about its lung tropism and nasopharyngeal and intestinal, but it's not limited to that. And this was data from postmortem of individuals who passed away from COVID-19, and we found the virus with tropism to their endothelial cells in the heart and the brain, and the epithelial cells in their kidney and pancreas. We also now have very good understanding of the transmission of the virus. So whether we can sit here and debate about droplet versus airborne, but I think what this pandemic taught us is, for the longest time, we've held this dichotomy of airborne versus droplet, where infections are really not confined to one or the other. And we knew that previously, whether or not we chose to ignore it. We knew that with influenza viruses, that even with influenza viruses, if you're performing aerosol generating procedure, there is a potential for this predominantly droplet transmitted virus to become airborne. So we know that's a big mechanism. The other one is deposition of the virus, and that's still being tweaked out. That was the deposition of the virus onto your mucous membrane, which then remains exposed once you've protected your nasal mucosa and oral mucosa via a mask. And that meant the eye protection. And I think it's for some reason it has been a big point of contingency throughout the pandemic. I think none of us can deny if you're doing an aerosol generating procedure, you need eye protection. There is also an abundance of data, from several countries that people who had eye protection were less prone to get infections. But it's one of the recommendations. I'll be honest, was the hardest to implement in both of the institutions that I worked at through this pandemic. What's been less, or more or less put down lower into an importance category is, touching the surfaces. So touching surfaces and then touching your own mucosa is probably less important in transmission. And same for fecal oral. So not the traditional fecal oral, but similar to the original or the SARS-CoV, where you had these outbreaks in buildings, so people getting infected kind of throughout the building. And the thought process was the people shedding the virus in their stool, getting flushed, getting aerosolized, and that's infecting secondary individuals. How much that plays a role for COVID-19 is not really, it's not the most abundant mechanism of transmission, and probably has a very small role. And we know that, our period of infectiousness is the peak. We're at peak of our infectiousness right before symptom onset, and we are positive for the RNA. The patients who have COVID-19 are positive for the RNA for a long period of time, but that does not reflect their period of infectiousness, which is far shorter. And just to introduce or reintroduce, I'm sure you've heard this term, since we'll talk about some of the vaccine data, I thought it was important to reintroduce this term of cycle threshold, which is the number of cycles or the number of cycles of amplification you need before you get to a detectable level. And so the lower number of those cycles are before you get to the detection threshold, that means you had a lot of virus. So a lower cycle threshold represents higher viral RNA loads. And generally, the FDA has never put a number on them, but a lot of the emergency use authorized tests that are out there, the CT value usually is less than 40 when we start calling it a positive. And in our most immunocompromised patients, I'll tell you, their cycle thresholds were sometimes 17, 16, 18, and that had very high viral loads in their upper respiratory tracts and lower respiratory tracts. But again, this is virus load, it's a RNA load. It does not represent live virus. It does not represent a culturable virus. So how much do we know about RNA positivity? And one of the unfortunate things I think we did on early in the pandemic is call it RNA shedding, which still sometimes implies you're shedding the virus. So I like to call it RNA positivity. So we know that individuals with SARS-CoV-2 infection, there are several large cohorts that are published. We know that they remain detectable for a very prolonged period of times. And sometimes the longest detection that we see is in the stool specimens. And this is something we used later on in the pandemic when we were seeing our patients with MIS-C, when we couldn't identify the SARS-CoV-2 to kind of meet that epidemiologic definition, that we were starting to look at stool PCRs, and there were not and are probably still not any authorized emergency use authorized FDA tests, but a lot of institutions like our own had our ingrown tests, which were validated internally to test for RNA in the stool. So it stays there for a long time. But does that mean if it stays there for a long time, how long is it viable? And early on in the pandemic, our initial understanding from many, many good studies was the number of 8 or 9. So there were very large studies and retrospect and systematic analysis of those, which showed that most individuals with mild or moderate symptoms, you really can't find the virus to culture after 8 or 9 days. And more lately, we came at that 10 days of the number where you can't find live virus anymore. Subsequently, as all of us started seeing our immunocompromised patients and they were having these very low cycle thresholds, some of our researchers within us did viral culture data. And this is one of such publication. There's several of these kind. And this study, there were about 123 individuals, about 70% of them were hospitalized, 2/3 of them also were immunocompromised. So when they looked at their shedding data, so here the x-axis is the duration of symptoms, and the y-axis here is their viral load in terms of RNA copies. These little orange circles are representing the detection of the virus by RNA or negative culture. So the virus culture is negative for these orange people, and the virus culture is positive for these black little squares. So as you can see, the virus culture was positive in quite a lot of individuals early on, but once you get to day 10 to 15, there really were a few stragglers left behind, and really no study has found these individuals also positive after day 20. And that's still, a little bit contentious, but there's been many, many studies that we haven't found virus. So it's probably up to day 20. And that's the basis of our recommendations that we followed, all collectively since the beginning or almost the midpoint of the pandemic, that most adults will recover within 10 days of symptom onset, or if they never had symptoms, then the first positive test, as long as they're afebrile, as long as the symptoms are improving. And for severe illness, or for our severe illness in the ICU patients and our immunocompromised patients, we may need 20 days. And then we always said, retesting and re-quarantine is not recommended within 90 days, even if they, have an exposure, as long as they're asymptomatic. And where did that 90 days come from? And it was from, our understanding of prior coronaviruses, SARS-CoV viruses, that, a lot of individuals had immunity for at least 3 to 4 months. They were not getting reinfected. And then we started seeing reinfection reports with SARS-CoV-2, which are limited. They're case reports, but they are definitely limited numbers. They're also limited by what kind of testing methodology they're using. Very few of them have really robust phylogenetic analysis to really say that your initial virus was different from your subsequent virus. Some of them did genomic analysis, but saying that my virus between my 2 episodes is differentiated by 2 or 3 single nucleotide polymorphism variation, that really doesn't cut it, because we know virus is going to mutate over time. And if it's a host, especially an immunocompromised host that's not clearing the infection, their virus on day 30 is going to look, if it's still there at day 30, is going to look different from what the virus was at day 1. But a lot of these reports were separated by 90 days. So when we really said, okay, this looks pretty good data for reinfection, most of these individuals were being infected at 4 to 5 months, but there are definitely some as early as 45 days. So it's by no means, a clear cut line at 90 days. But then also more and more time as we're spending from initial patients who were getting infected, we're starting to get good data about what kind of immunity. And I think immunity is a big word. I think what we're studying right now is what kind of immune correlates are these individuals having. So what markers of immunity to SARS-CoV-2 are we able to find in these individuals who were infected? Do those markers represent really protection or correlative protection? No. Currently, we have no correlates, immune correlates of protection, because if we did, for many of these vaccine trials, all we would have to do is find that immune correlate and do that titer and call that positive and negative and find your efficacy data. But that's not how the trials were run. They were run on endpoint of clinical disease. So but there's good data now. And it was actually 2 studies that were being highlighted today that have shown these immune responses or plasma B cells to be present in bone marrow even up to 12 months. So I'll highlight 2 of these studies. So this one study was individuals, there were 100 individuals, half of them were symptomatic and half of them had asymptomatic infection. In almost all of them, they mount to IgG response, which really peaks around 2 months, and then it kind of dwindles down, but it always remained at the above the level of detection. And that's what's also coming out of the newer data. Even at 11 months, the IgG response is still there in these individuals. Then they said, we're paying a lot of importance to these IgG. What about a T cell response and the memory B cell response? And in this study, they took T cells from individuals who were infected. In vitro, they stimulated with SARS-CoV-2 protein, and that would have the T cells make interferon gamma, which can then be pecked by enzyme-linked immunosorbent assay. And almost all individuals had a T cell response which was variable. And they found that, the variability of the T cell response correlated with their initial symptoms. If they had more symptoms, they had more T cell response, but this was not persistent or consistent throughout studies. And it also correlated with their peak antibody response. Another response that has stayed consistent through all the data that we're getting is our host response after infection is predominantly CD4 as compared to CD8. So CD4 are your helper cells that are going to help your memory B cells down the lane produce antibodies. So that's a good, part of that story. This was another study that looked at, they said we're going to look at all of the correlates that we can find, all of the cells. So we're going to look these individuals for IgG, whether they have memory B cells, CD4 cells, 8 cells, and IgA in the mucosa. And these colors basically represent how many components of the immune system were activated in these individuals and how long they persisted. So as you can see, a large majority are in this black color, which mean they had all components. They were positive for IgG and A and B cells and CD4 cells and CD8 cells. And almost all of them have some color. So even the one with, that's in white, even those had two components of their immune system. So in this study, 95% of the individuals had at least 3 out of their 5 immune system components that could recognize SARS-CoV-2 even after 6 to 8 months of infection. So we know that. So I think because of that data of reinfection and because of this data, which actually might extend our 90 days, but right now the recommendation is still after an infection, if you're re-exposed within 90 days and you're asymptomatic, you don't need to be tested. If you're symptomatic, especially if you've been exposed and if you have symptoms that are consistent with COVID-19, you don't have any alternative etiology, then yes, those may need to be tested. And then it becomes really important to identify these individuals, and the CDC has very good definitions on how to define reinfection, because then we need, genomic analysis and variant analysis in these individuals. So what's the second infection happening? What's special about this individual to cause the second infection? And that, data I think is still being worked out. How about variant viruses? And I think this landscape of reinfections is being complicated by variants. We now know of reports of reinfections from Brazil, UK, and South Africa, not very robust published data, but just kind of reports from here and there. So we know that our reinfection risk may be increased in the future with exposure to other variant virus strains, which are not going to be neutralized by the immune anti-sera for individuals who were infected before. And we'll talk about vaccine at the end. So just since we're introducing variants, what are they? We all know variants, all viruses mutate. There is an inherent mutation rate. And through that process of mutation, a virus will come to recognize a part of it that has a fitness advantage. And as the number of infections, so we know from both in vitro data and large population data that as the number of infections in the community increases, the evolutionary rate of the virus increases. The virus divides more rapidly, mutates rapidly, and starts to recognize its fitness advantage more rapidly, leading to selection of variants, which is why, this disruption of these rampant areas of transmission is so important to control of variants. Another another piece of importance there is immunity. Whether you think about that as terms of herd immunity, so having immunity in a large number of people, so we're not seeing these transmission chains and these mutation, or whether you think about it in a single individual. So we all have immunocompromised patients, and we know our immunocompromised patients whose immunity is not able to clear the virus lingers in their system for a longer period of time. And the longer the virus is evading the immune response, it starts to select for mutation and it starts to select for variants. So that's generating, it's quite a bit of academic work in institution where they had immunocompromised patients and had these viruses that may have selected for variants in those individual patient population, which is, a scary prospect when you think about it. And just, not to go, I think just a basic understanding of what the variants are, what makes it a variant of interest is basically we know these variants have a genetic mutation. So all these E484K, the things we hear about. So basically we know, okay, it has the genetic marker that we know is going to change its receptor binding. We know it may impact its neutralization. We know it may predict increased transmissibility, but we're not seeing that yet. We haven't proven that yet. So it's of interest. And it's of concern that once we have proven that, once we know that this virus has increased transmissibility, significant reduction in neutralization by some of our monoclonal antibodies or some of the immune sera generated by a vaccinated individual, and our treatments are not very effective, even our diagnostic tests might not be picking that virus spike protein, then we call it a variant of concern. And they don't have to meet all of those criteria to meet a variant of concern. And then the variant of high consequence, which luckily so far we have none of them in the United States or elsewhere in the world, is where we know that all of our prevention measures are failing. So our medical countermeasures, including physical distancing and masks, are not effective, and our vaccines are not effective. And I really hope we don't get there. And I think the only way to avoid that is get to the vaccines to a large number of people before we have the ability to get to that point. So these are the variants of interest on the left and the variants of concern on right that are currently in the United States named by the CDC. So the variants that are circulating and postulated to be circulating in large numbers, and we're starting to get some early genomic surveillance data from India, are the B1617 and its subsequent variants. It's not become a variant of concern yet in the United States. We're starting to see it in parts of the country, including, our very own California, but it's not at large numbers. What is at large numbers nowadays is the B117, our UK variant, the P1, which was the Brazil, but they were first detected in Japan, but these people had traveled from Brazil, so it's largely in Brazil. B1351 in South Africa, and our two personal California strains, the Cal-C strains 427 and 429. And again, this is the genomic COVID tracker from CDC. And, I spend more time than I should and on some days on this website. So B117 is definitely the predominant lineage right now. It's about 67% of all cases in the United States currently are B117. We're seeing some of that 526, which was the New York one, some of the P1 strain, but also some 617, 1, 2, and 3. So very small numbers, but it's there. And these are different proportions of these variants, with this light color being B117, the UK strain. And this is representing data through all the HHS region and us being in region 9. So that's the California data. So how about vaccine? And I think we deserve collectively to celebrate just for 2 minutes if we can. The success story that is COVID, the innovation for COVID-19 vaccination, from getting or hearing about first reports of these mystery cases of pneumonia in 2019, December of 2019, to having the genomic structure identified early in 2021 and having it shared worldwide for the scientists to work with, to having an actual vaccine product and having it emergency use authorized, to having it in the arms of individuals, including, I'm sure, many of us by December 2020, is truly a success story where, for all these other diseases, if we talk about the first point where the infectious agent was identified and linked to the disease, to the point where you had the vaccine, we're not even there for many of them, but we're there within a year. For one of the ones that, you have to agree at the pandemic level was really important for us to control it. And, so just, back to the basics, what are the approaches and for vaccines in general? For one is approaches you can approach as a nucleic acid vaccine. So you're going to say, I'm just going to take the RNA or the DNA or maybe the mRNA. I'm just going to inject it to an individual. Somehow I'm going to make them immune to this virus. Or you say, I know the spike protein is the protein that's immunogenic, so I'm just going to take the subunit and inject it into an individual. And that's the subunit approach. Or you take the whole microbe approach where you say, I'm going to take the virus and inactivate it and then inject it, or I'm going to live attenuate it, which hasn't been done yet. It's going to be tricky. and a viral vector vaccine. So I'm going to take a component of the virus that's immunogenic, but I'm going to find another virus as a vector. So something which is a non-pathogenic human virus. So it's not pathogenic to humans. I'm going to use it as an envelope, as a vector, and then deliver the vaccine. So that's kind of the basic idea of all these vaccines, right? So, and that defines where we think of our vaccines that are available within the US and outside of the US at large right now. So your mRNA vaccines are your Pfizer and Moderna vaccine. Your adenovirus vector-based vaccines are the Johnson & Johnson and the Janssen vaccine, which is utilizing the human adenovirus 26 as a vector, which is not pathogenic. Or your Oxford AstraZeneca vaccine, which was in the UK, which was utilizing the chimpanzee adenovirus vector, which again, not pathogenic to humans. And Covishield was the product, which was a collaboration between AstraZeneca and India's own local production, Bharat Biotech, and basically that's one of the vaccines that's available in India right now. And then Sputnik 5, which also is an adenovirus, and they use two vectors, 26 and 5. And when you talk about inactivated vaccines, vaccines that are predominantly, at this point available in China, so Sinovac, CoronaVac, Sinopharm's vaccine, and also Bharat Biotech's Covaxin vaccine, which is in India. There is a Novavax, lipid nanoparticles, protein subunit, spike protein-based vaccine, which is, I believe, currently not authorized for use in any part of the world, but that may have changed since the last time I looked at that. All right. But what do we know about vaccine efficacy data? And I think it's very important for all of us as pediatricians to know this, because this is something we need to be well versed with. So when we're talking with our patients, we know and can say with confidence if the data is in our mind, and we can say it what the numbers were. And the numbers are easy, very, fairly easy to remember. So we know for the Pfizer vaccine, I took this data. There's sometimes you see different numbers. The FDA documents, because FDA does their own analysis of the data, sometimes their numbers look a little different. I took the data from the final publication, the peer-reviewed publication from the manufacturer. Again, was very subtle, I cross-checked with the FDA data. But sometimes where it's a final publication, like for the adolescent cohort, is not readily there yet. Then I looked at the emergency use authorization document from the FDA. So your Pfizer vaccine, in the cohort, the first cohort that was published, 16 and older, was large patient population that was studied, about 40,000 individuals. These were definitely trials that did their due diligence to try at least to enroll and reach out to minority population and expand their cohort for minority populations. So about 1/3, get about 28% were Hispanic or Latinx in this cohort. And the vaccine efficacy was 95%. So 8 cases of COVID-19 in their vaccine cohort and 162 in their placebo cohort. Very effective against for severe disease. So 1 case in their vaccine cohort and 9 in their placebo cohort. And similar data for Moderna vaccine, 94% efficacy and 0 and 30 severe disease. I think this 0 was in the FDA documents did become 1, because I think that individual did get a severe disease at about day 30, after day 30. This is the Janssen vaccine data. Still very large patient population, good diversity. Their day 14 efficacy was 67%, and that's against all COVID disease, and 66.1% at day 28. But again, in excess of 90% for getting into severe disease. So 85 to 95% once you get into severe disease. So it's still a very good vaccine. And we'll talk about some of the issues with individual vaccines later. The Pfizer data for the adolescent vaccine was 2,000 individuals, and here there was also immunogenicity data. So one of the primary endpoints, because we know the number or the burden of disease was not that high in this cohort, one of the endpoints was, is it as immunogenic as the adult cohort? So is our vaccine going to produce the same geometric mean titers as the adult vaccine is being produced? And it was higher in the vaccine cohort in the pediatric population. So it met its primary endpoint. but also the disease endpoint was 100% efficacy. So there were no cases of COVID-19 disease in individuals who got the vaccine, 16 in those individuals who did not get the vaccine. And I'm sure you all heard this past or this very week, this last Tuesday on May 25, Moderna announced, so this was just a press release, which is how we learn a lot of data in the world of COVID, for anything, any medication and any therapeutic product. So they announced their early results of their Teen Cove study, which is their cohort, which is 12 to 17 years of age. There were no cases. That cohort also, there was 100% efficacy. There were no cases of COVID-19 that were observed after 2 doses of the vaccine. And their primary endpoint of immunogenicity also met non-inferiority compared to their greater than 18 cohort, which was already established and published. So they have announced, Moderna has announced that they plan to present this data to the FDA early June. So hopefully we'll have another vaccination that is authorized for use in adolescents or later next month, early next month. How about data from Pfizer from the younger cohort? So from anywhere from 2 years to 12 years of age. I think those data are underway. I have not heard any early results or any signals, but hoping that data will come out soon over the summer before fall and get another vaccine authorized. So back to this idea of immune protection, and I think it's something we as pediatricians need to be aware of. For the longest time, we know that we do not have, even to this day, a good correlate, an in vitro test, a lab test of immune protection. So yes, your antibody test could be positive. Yes, your quantitative antibody could be very high titer. Yes, maybe you can even go and find a lab that will do a fancy T-cell analysis of your cells against SARS-CoV-2, but none of that affords, none of that is the definition of immune protection at this time. And the other problem with many of the lab tests, I'm sure you all know with the antibody tests, is with so many of them on the market, what's their sensitivity and specificity and negative and positive predictive value for each one of them is definitely a tricky landscape to navigate, and getting what test a patient got and where that test was and what the specifics of that test are. And then also to make sure that the tests these individuals are getting are testing spike protein antibody, because if they're testing for nucleocapsid antibody, that's not going to be the same as a vaccine protection, because the vaccine doesn't have the nucleocapsid. And then the other part is we're just paying attention to the antibody. What about, again, we said previously, what about the T cells and what about the B cells? So the FDA reiterated that as recently as May 19, saying that antibody testing, be it qualitative or semi-qualitative, quantitative or quantitative, is not currently recommended to assess immunity after COVID-19 vaccination, because I feel like we're hearing even on our listservs a lot of this questions and people starting to do these things. And one place where this was being done was for immunocompromised patients, which was leading people to say, oh, my patients are immunocompromised. All of the data I'm seeing, they're not mounting an antibody. So maybe they don't, maybe I just don't give them a vaccine. Maybe I give them a third dose. So the American Society of Transplantation has come out and recommended against such practice and say, don't do that. We don't know about the T cell and B cell correlates of protection yet. So please give them the vaccine and don't check antibody responses. There was an interesting publication recently, which hasn't caught as much steam, but they did do neutralizing antibody levels, which again, many of the commercial labs, they're not doing neutralizing levels. It's not even established, but in this study, they felt that they represented data that showed the neutralizing antibody levels were highly predictive of immune protection from symptomatic infection. And when they looked at how much neutralizing antibody level they needed for about 50% protection against detectable SARS-CoV-2 infection, it was only 20% of mean convalescent sera from individuals who had recovered from infection. So it's definitely a landscape we need that we currently don't have. And I think we should have it soon, because I think it's high time to get an immune correlate of protection. again, simple representation. We all know this, which ages it's authorized, how many weeks it needs to be separated, and when you're considered vaccinated. We all know that's 2 weeks after your second shot is when you're considered immune and vaccinated. With the vaccine comes vaccine safety monitoring, which is our job, as all providers were required to report all and any adverse events. And I will also highlight, I think one thing we don't recognize is something we got a lot of calls about people inadvertently giving the wrong dose or the wrong site, or giving it the dose subcutaneously, or giving the Pfizer vaccine to a 15-year-old when it was not authorized. So those are all administration errors. And even though they did not result in harm to the patient, those administration errors also need to be reported to the vaccine adverse event reporting system, and that is the VAERS. All of us as providers are required to do that. So the VAERS, we all know, easy to find, easy to report, and it's co-administered by the CDC and the FDA, and has generated very good data through this pandemic to try to find early signals of things when things are not going right. And the other system is the vSafe system, which was the new system that CDC developed especially for COVID-19 in this era of social media. This was a phone app. I'm sure maybe several of you got it. I definitely signed up for it after I got my vaccine. You definitely should encourage your patients to get it. It's a secure app. You basically go to the CDC's website and download the vSafe app, and they check in, and it's kind of annoying text that you get for a few weeks. But it becomes, I think, once a week, and then once every other week, and it stops. Why is it important? Even we have VAERS, I think vSafe is one of the systems that allowed the CDC to publish their largest cohort yet from pregnancy and birth cohort. And because of that data, there was from all these pregnant women who got the vaccine and put their own data in vSafe, had no adverse effects. And that became one of the big reasons for ACOG's, strong recommendation to provide vaccination during pregnancy and lactation. So vSafe is definitely something CDC encourages all of us to encourage our patients to use as their own monitoring system, but doesn't relieve us of any responsibility as providers to report things to VAERS. And through the trial data and post, and so this is a systematic review of all these side effects that have come, and they kind of organized into the types of vaccine, the adenovirus vaccines, the RNA vaccine. So we knew early on the reactogenicity data, right? None of us went into getting the vaccines or promoting the vaccines knowing that there is no reactogenicity. We knew that there's quite a bit, like 80 to 90% is a large percentage of dose that's going to cause reactogenicity with your second dose. So those are your injection site pain, your tenderness and redness and swelling and induration. We all knew that going into getting the vaccine. And this was the vSafe surveillance system, again, another data publication, and just highlighting this part, because I think we all know about the injection site pain. I also, would encourage us to be cognizant and maybe tell our patients, because sometimes we get a lot of calls about nausea and vomiting and dizziness. And, those are also expected systemic reaction from the vaccine. They're not at the same number, so we don't hear about it as much, but the individual who gets the vaccine and who gets a lot of nausea, and I was one of those. I got my vaccine very early on in the December, the first week when it came on, and I had terrible nausea and almost positional vertigo, and I had to go scramble through all the trial data. Is this a COVID vaccine side effect, or did I actually happen to be the unlucky one who got COVID right after the vaccine? So something to keep in mind as clinicians and pediatricians ourselves, to counsel our parents and patients. COVID arm was another interesting one, and that was post-vaccine. I think we didn't hear about it in the trial data, but this is now well described, well published. So this is basically a delayed type hypersensitivity. It's a T cell hypersensitivity. We know that through skin biopsy in these individuals. It's a local or sometimes removed from the site of infection. So there are definitely individuals who get it on their palms. There are definitely individuals who get it on their elbows, but many a times it's at the site of injection. It's not, it's seen with dose one, dose two. There's not really a big correlation. Is it going to get better with dose two? It's going to be worse with dose two. Several times it's not as bad with dose two, but there are definitely individuals who have it with both doses and looks pretty impressive and gnarly with both doses. So again, expected, known, described. It's a delayed hypersensitivity reaction, so it's not a contraindication to subsequent vaccination. Another one we heard post-vaccination, which in hindsight, the trial data did have some of it in their reports, but I think we started hearing about it more after we gave the vaccinations. We heard about individuals having axillary lymphadenopathy, cervical lymphadenopathy, some reports of submandibular lymphadenopathy, to the point, I think the reports started being published in radiology journals where these individuals who were getting routine x-rays or CTs for their cancer chemotherapy or cancer staging, or the other big population we heard was in, women getting their screening mammography. So the, now the screening authority or recommendation overseeing individuals have now recommended, or their bodies have recommended, to either get the screening mammogram before your first COVID vaccine or delay the mammogram 4 weeks after your second dose of the COVID vaccine. So you're not seeing these signals of lymph nodes that's going to unnecessarily trigger subsequent testing. So we can keep our patients safe, from these unnecessary tests. And anaphylaxis, that was a big one we heard after. And again, this is the beauty of the vaccine adverse event reporting system and all the safety systems that are in place. So we started hearing early on about cases of anaphylaxis. This is one of the reports that was published. For that, the median age of these individuals is about 40. There's no gender predilection. A large number of these reports, or the anaphylaxis that has been reported, is within the first 10 minutes, 80% within 15 minutes, and by 90% of them within 30 minutes. But there are some outliers there outside of the 30 minutes. But what's important to remember is a lot of these individuals who had anaphylaxis had a history of allergy, and it's big, vague allergy. Like these people reported, okay, I had allergy to influenza vaccination. Okay, that's a big one. I had allergy to latex, or I have food allergies, I have pollen allergies. So those individuals were definitely part of this cohort. And 1/3 of these individuals who got anaphylactic reactions to the mRNA vaccine had a prior history of anaphylaxis. So these are definitely high-risk individuals that need to be identified at the time when we're giving the vaccine, so we can prepare and monitor them for that good 30 minutes. And it happens with both first and second dose, more so with the first dose than the second dose. And the rates, just something we always tell our patients, it's not very frequent. It's anywhere from 2.5 to 5 cases per million doses, but it's very dependent on your cohort. So we'll go through kind of that stratification. And here is that. And this is from the CDC's interim guidance for COVID vaccination. People who have a contraindication, who are those people? People who get a severe allergic reaction like anaphylaxis after a dose of a vaccine. So that usually happens with the mRNA vaccine. So if you have anaphylaxis with one mRNA vaccine first dose, you cannot get the other mRNA vaccine. You may be able to get the Janssen vaccine, and you have to kind of proceed with caution. So yeah, contraindication to one mRNA vaccine, you may get Janssen. You need a thorough risk assessment, get their other allergy history. You may want to consider referral to an allergist specialist, especially in these cases of anaphylaxis, and definitely a 30-minute observation period for these individuals. So definitely proceed with caution in these individuals. The other thing you want to do is, which is easy to do, on the COVID-19 CDC's interim clinical guidance, they have an appendix of what are the components of the vaccine. And it's not a huge page, I promise. It's not an exhaustive table. It's a very clean-cut table. So, for example, an individual may have a polyethylene glycol allergy. It's not very common, but that's a component of the mRNA vaccine, or a polysorbate allergy, and that's a component of the Pfizer vaccine. So just having that information ahead of time, so you can stratify that individual's risk and either not vaccinate them and get them to an allergist referral if they are really that high risk and have those components that are contraindicated. And there are people also who will say, I have an immediate allergic reaction to, like an anaphylactic reaction to influenza vaccine. That's again a precaution, or like injectable therapies, so people who get, not the allergy shots, but all of the others, subcutaneous injections, then those are people you might want to refer to an allergist as well. And then the last group of people is, a large cohort of people who say, I'm a family history of allergy, or I'm allergic to some medication or some latex or pollen or environment or something. And for those, 15-minute observation, and if it's an anaphylactic of any kind to anything, then at least a 30-minute good observation. So just having a good plan, going in with a good plan for these people with allergy will get us a long way. And the other one to remember, especially now that we're immunizing our adolescent population, is always remember adolescents tend to get vasovagal reactions, and that's important to differentiate between a vasovagal reaction and anaphylactic reaction. And CDC also has a very good table for that. And also always to remember that, vasovagal reaction or syncope happens in adolescents, especially in the first 15 minutes after a vaccine. It happens in adolescents and young adults. And I think we all saw early on TV, some people kind of passing away right after they got a vaccine, which made for, good TV for, not good, but unfortunate kind of TV clips for these media channels. But, it's something that happens and something we probably want to tell the parents of our adolescents. But I think it happens with all vaccines, with Gardasil, with Menactra, with HPV, and, all of those. So just maybe being careful as they're getting out of table or getting off the table, so people are not passing away as they're in your office, and just have them sit for 15 minutes. And how about, thrombosis with thrombocytopenia syndrome? And it's something we will encounter as a question, even as pediatricians. We know it was, it was first reported with all of the adenovirus vector vaccine, and that's where it's at. It was reported first with AstraZeneca, and then we started getting reports with the J&J, which led the CDC to put a pause on April 13, and the ACIP, very publicly reviewed that data and affirmed their recommendation for its use. What is it? It's basically, these were individuals that, had a severe thrombosis. So these are individuals who get a cerebral venous thrombosis, or a combination of venous or arterial thrombosis, splanchnic thrombosis. But unlike people who get clots, these people have thrombocytopenia. So they were looking very similar to us in the hospitals, to people who have the rare kind of reaction to heparin, where they get a heparin-induced thrombocytopenia, and it's an immune-mediated thrombocytopenia, which basically they have platelet-activating antibodies to platelet factor 4, and those are positive in even these individuals with TTS, which is associated with vaccine. We know from the publications, from the reviews, and from the CDC alerts that this was more common in women under the age of 50. So the rate was 7 per million doses under 50, 18 to 49 years of age group, as opposed to 0.9 per million doses in the older age group, or not older, over 50 years of age group. And the management of these individuals, I think you've all heard, as if you're a hospital-based physician, really being cognizant if that's thrombosis with thrombocytopenia, that heparin is the wrong thing to do in those individuals. So they need non-heparin anticoagulants, or IVIG has been shown to be really effective in these individuals. So you always want to get the platelet factor 4 antibodies, get a hematology consult going, and manage that way. How do we think as pediatricians about vaccine considerations for these individuals? So one is, you have an odd patient who really had a history of heparin-induced thrombocytopenia. So the CDC says if that happened within the past 90 days, then give them a non-Janssen vaccine. But if it happened after 90 days, then go ahead and give them any vaccines. More than 90 days ago, they had a HIT episode. But we have a lot of patients who have, thromboembolic events, and we even have teenagers who are on oral contraceptives, or people have, other thromboembolic events that are not associated with thrombocytopenia. That's not a contraindication to J&J vaccine, because those thromboembolic phenomena, their mechanism is very, very different compared to this immune-mediated thrombocytopenia. The other questions we're getting for the Janssen vaccine is, do we put our patients on aspirin or use some sort of anticoagulant as a precaution? And that's not recommended. I will say that, the ACIP did not put any specific language under 50 years of age, whether or not there is specific people or women that you want them to consider an mRNA vaccine. But the CDC on their interim clinical guidance page for vaccination does have language like, you definitely want to tell people who are under 50, women who are under 50, that there are other options and other vaccines available. So right now, it's not going to be a big issue. I think we have some of the 18 plus in our patient population. And even for the younger one, a lot of the vaccines we're getting is now Pfizer followed by Moderna. But once J&J enters that space, those discussions will become important for us. But none, no, and we don't have data in that age group because the vaccine was not authorized in that age group. And how about these? And I'm sure you've heard this. This happened last week. Dr. Chen probably knows, Tempe Chen. This was, we were getting on our ID listservs. We started hearing about these cases of myocarditis. And it also happened, I'm sure, on other listservs. We started hearing of this on the rheumatology listservs. So this is a very early report. It's not even at this point, the AAP and the CDC have both released data and are not sure if this is just a coincidental finding or is it related. So what they're seeing is that these cases of myocarditis are happening in adolescents. They're more often in males. They're more often after dose 2, and they're typically happening within 4 days of the vaccination. And these children are doing pretty well, very mild cases, and some of them were getting indomethacin and were getting better. And they now have said, at least at this point, with their current safety systems, the rates of myocarditis reports in the window following COVID-19 vaccination have not differed from expected baseline rates. So that's what we know currently. And today, I think one of the listservs was postulating, as we said at the top of the hour before we started talking, we're having a discussion. There are parts of the country that are seeing spikes of RSV infections. There are cases we're seeing more cases of enteroviruses and seasonal viruses and summer viruses. So is this rise in cases of myocarditis, is it related to the vaccines, or is it finally related to our change in behaviors that we're coming out and mingling together and getting virus infections and myocarditis? Regardless, I think the biggest onus now, and I think the CDC has earned respect from it. I'm sure a lot of us, and especially with their early alarm with the Janssen vaccine, with the TTS cases. And so I'm confident they'll do the same justification to myocarditis. So I think they didn't need to release this report because this was very early report, but they were upfront and honest, as they are being, with very careful with anything vaccine associated. So something to keep in mind. Again, I'm highlighting the interim clinical considerations. If there's one page you want to save through this vaccine time period, is this page, talking about interchangeability of the vaccine. They're not interchangeable other than that contraindication, the allergy thing we talked about. They do give you a grace period of like 4 days. If you give the dose early, fine, you can count it. If you have to delay it, maybe 6 weeks. That's really not recommended. The biggest change recently that happened was now you can co-administer COVID-19 vaccine with other vaccine, regardless to the timing. So you can give the COVID vaccine the same day you give the Tdap vaccine or the HPV vaccine, or within 14 days, either way. The other one is the TB testing. If you have to do TB testing, it's not a contraindication to not do TB testing. You may need TB testing for many reasons, but it's okay to do it on the same day. It's okay to do any day prior. Right now, they're saying don't do it within that 4 weeks after COVID-19 vaccine, and they don't have strong data. So they're kind of applying the MMR data. So we know once we do MMR vaccine, there's some decrease in immunity and then your vaccination needs to be delayed. So your TB test needs to be delayed. So that's what they're saying with it. And then lastly, people who are vaccinated outside of the US were getting those questions. So I think if it's a vaccine authorized by the WHO, at least has listed, then fine. If it's not even listed by WHO, then they may want to get another dose of vaccine when they're here in the US. People who are infected prior, definitely give them the vaccine, make sure they're out of their quarantine isolation period. People who have MIS-C and MIS-A, There, the data is really not clear. We know those people have high level of antibody titers. We don't know if those are protective. So right now the CDC is saying maybe they're really protected for the first 90 days. We don't know how the immune things is going to correlate, but depending on the risk benefit, like how much community transmission, you may want to delay that vaccine for 90 days after the diagnosis of MIS-C and MIS-A. How about convalescent plasma monoclonal antibody? Just got this question today. My patient had a vaccine a month earlier. Now she had COVID-19. Can she get monoclonal antibody? Yes, please do. Go ahead and treat them the way you would treat otherwise. And, you know, if vaccinated people who get these subsequently who develop COVID-19, it should not change any of your management. If there is an outbreak, should I go ahead and vaccinate everybody? It's probably a good idea to do once they're out of your quarantine period, but it's a short incubation period, so it's not a strategy to control. I will highlight the CISA COVID Vax project. So that's also on the CDC's website. So if it's a very complicated question or it's a question you've gone through the clinical guidance and it's still not making sense, the CDC is available to answer any of our clinical questions from any of our clinicians within the United States. And, you know, vaccine effectiveness study, I'm really running out of time, so I'll skip through a lot of this. So the real-time vaccine effectiveness data, you know, we know the trial data, but there are very large number of publications coming out for vaccine effectiveness, and 94% effective in preventing symptomatic COVID-19, 94% effective in reducing the risk of being hospitalized. We're also getting data for COVID-19 infection, this like controversial question of does it prevent transmission or not? We're finally getting data. This was like from the healthcare responder, first responder network. Those who were fully vaccinated were 90% less likely to have an infection, like an asymptomatic infection. And this is data from all the studies that have been published to date that show that COVID-19 vaccines reduce asymptomatic infection. If they're reducing asymptomatic infection, the hope is, the idea is that that's preventing subsequent transmission. And there's only one real world data published from healthcare household secondary contacts from UK that showed that decreased disruption in transmission at the rate of about 60%. So it's definitely doing that. We also know viral load data. So this is cycle threshold, you know, our good old cycle threshold friend. The lower it is, the higher your viral threshold is. So people who had SARS-CoV-2 vaccination starting at about day 12 post-vaccination, if they happen to get infected after day 12, their viral loads tend to be lower. Cycle threshold tends to be higher, but they tend to have less viral loads. So hopefully they're transmitting less. So those are all data supporting less transmission. And how are they performing against variants? Lots of good neutralization studies in vitro, slightly lower maybe for B1351, but a good amount of neutralization for everything else. But if we talk about real world data, still very effective, especially in parts of the world where these variants were prominent. The Janssen effectiveness data is, you know, a little bit on the lower side, but for severe or critical disease, it's still 73 to 82%. So it is still good vaccine. Lower side, but that's same as their general effectiveness data against normal wild type, if you want to call it, COVID virus, and not against the various. So same data, same results. Last thing, this was an interesting report published this week, how many COVID-19 vaccine breakthrough infections, you know, I'm very interested in this. We're all vaccinated. How many people are getting breakthrough infections? So this data was published last week or this week in MMWR. They've published about 10th from all millions of people that have gotten the vaccine. They know, at least reported, so it's probably, you know, less underreporting, but 10,000 individuals who had breakthrough infection with a median age of 58. 1/3 were asymptomatic, 10% were hospitalized, but 1/3 of them were hospitalized for another reason. There were 160 deaths in this cohort, which the deaths were in the older age cohort. And some of these deaths were not related to COVID-19. How about sequencing data? Very small number of these things were sequenced, but 64% of them were variants. Does that mean it's the variant, it's because the vaccine failure because it's a variant? I don't think so, because the proportion that you're seeing of these variants in this study, it reflects the proportion of variants that are currently in circulation in the US. So any 63% of current infections are B117 anyhow. So with that, I'll end. And I'm sorry for going over, but I will go through the chat with the help of Dr. Teresa's, and we can answer any and all questions.
Well, thank you so much for the. Let me get my microphone. Thank you so much for the fantastic presentation. We do have a few questions in the chat. And first was Dr. Sharon Pollack asking, now that our case counts are lower, and given that the positive and negative predictive values have now changed, which tests can be considered reliable in suspected ill patients?
So that's a great question. I think we've had this intense debate of PCR versus antigen testing. And I think at this point, if your case counts are lower and you're really trying to find out if this person is truly infected or not, I would go with the PCR testing. The antigen testing, I think, is useful, but their false positive, their positive predictive value is not very good, and the false positive rates tend to be high, sometimes even as high as 40-30%. So I think those are good when you're dealing with a large burden of infection. You're still just trying to control the number. So I would go with PCR nowadays.
Thank you. Another question by Dr. Pollack. If running a sleepaway summer camp, what is a good testing protocol to keep campers and staff safe in the summer?
It's a little, we might want to talk one-on-one about that question. I think it's a little bit of an involved discussion, and it depends on the size of that camp, and depends on the age distribution of the population with it, and depends on the people that are vaccinated or not vaccinated, that percentage breakdown, and the facilities or and the availabilities of the testing. So I think I would use all of that to develop a protocol for that population.
So, if the UK variant B117 is the predominant variant in the US, could that mean that one would be safer to travel to the UK than to travel to Brazil, for instance? Is our immunity variant specific?
That's a great question. So from the all the neutralization data is showing that our vaccine afforded sera are neutralizing P1 and B117 to similar extent. The B135-1 in South Africa is the only one that our neutralization sera does not have that much efficacy. We don't have real world vaccine effectiveness data. Actually, we have for both B117, not so much for P1. But I think we currently don't have data to say that it's not safe to travel, for example, to Brazil. I think in vitro data, if we were to believe it, it's pretty similar for both B117 and P1.
Okay, but then you would say that it would be a bit unsafer to go to South Africa.
Yeah, I think if I was into the market of placing bets on where I would be safer, I would bet on UK.
Okay,
Yeah.
okay. If aspirin is not recommended as prophylaxis for thrombosis, what about days or weeks after you receive the vaccine?
Yeah, no, that's a good question too. So it's because the mechanism of it's an immune mediated kind of mechanism. It's not been shown at this time that taking any non-heparin anticoagulant or aspirin as a safety thing was going to impact the rates of that TTS. So yes, I think, but that data is evolving. So I would keep eye on the CDC interim clinical recommendations, but at this time, they're not recommending such strategies.
Okay. I don't know if you already addressed this. Dr. Rajashekar, other than thanking you for the excellent presentation, it was asking, what do we know at this time about the multisystem inflammatory syndrome in children and the long-term follow-up?
So we know little. We know, I think I want to say, and I'll have Dr. Chen also chime in. I know little mostly from ID listservs. There were starting to get publications now that were almost 6-7 months out for several of these individuals, because we started seeing this in April and May of 2020. So for several of them were a year out. Most of the data is very reassuring. So it's been on the good side. I've heard anecdotally of a couple of case reports where these individuals who had normal cardiac function at 4 and 6 months later started to have some coronary dilation and some impairment in cardiac function, but that's a very anecdotal through a listserv on a couple of individuals. So overall, yes, Dr. Chen is correct. We've heard that they're doing very, very well all this time out.
Okay, for those of you not looking at the chat, Dr. Chen said that the patients that she has seen also are doing fairly well as well. I don't have any more questions that have come to me directly. Does anybody have any further questions? We can have a couple of minutes, and you are free to unmute your line if you would like to ask the question directly.
It looks like Dr. Saul has a question.
Yes, I had a question. Two things. One, the studies they're doing on infants 6 months and older, are they doing the same dose as in adults, or are they using a lower dose? That was question one. And question two was, I've heard some anecdotal cases of people that are being in remission for cancers, like breast cancer, that are getting follow-ups after the COVID vaccine and they're having relapses. Is that fake news, or is that something that reliable people are seeing? Because I know you're seeing adenopathy after the COVID vaccine, but these are people who had biopsies of the adenopathy that were positive. Is that just coincidence, or is that something people are seeing?
No, very good questions, both of them. First one, I actually don't know the answer, the dose that is being studied for the 6-month cohort. It may be, I would assume it's slightly different, but I don't know the exact dose and the exact proportion that's being used in that age group. The second, I'm going to call it hypothesis or rather than fake news. I have not heard it. This is the first I'm hearing from you of such, and I'm not surprised. I think throughout this time we've heard of things which have been kind of out there. So I think it's important for us to watch that space, but just from a standpoint of the CDC having been so transparent about all of the other side effects, I think if they had a signal of this kind of side effect, we should have and would have heard from at least a little bit more reliable sources by now. And we haven't heard any such reports. So fake news.
Thank you. Thank you very much.
Sure.
Anybody else?
And Dr. Chen also put in the chat that their colleagues at the FDA and have not reported on this either. So it's good to hear. All right, I think.
Well, with that, I guess we can close for the evening. Thank you so much for this wonderful presentation, Dr. Kaur. And if any more questions do come up, we would channel those directly to you so that we can either send the responses via email or post them on the web page that we have created on our website. Just so you know, the video will be online in a few days. Also, the evaluation, you will receive that tomorrow directly from Chris Kabinag. And CME, for all of you who are attending tonight, will be available in about 4 days. So thank you so much again for the great presentation.
Thank you for having me. Thank you
Thank
all.
you.
Have a good evening.